Students, today we will talk about the hypothyroidism, and I will start my talk with a case scenario. A 32-year-old female executive in a multinational organization started having low mood, lethargy, lack of initiative, and drive. She had been receiving excellent performance awards for last 3 consecutive years, but was not even considered for regular annual promotion this year. She got frustrated over this neglect and started using antidepressants on advice of her general practitioner. She was repeatedly found somnolent in her office, and the pile of file in need of her comments swelled up. Her boss arranged a psychiatrist consultation. Laboratory screening was ordered, and a medical consultation was advised. A lady with depressed mood who is slow to respond to questions reports being lethargic, somnolent, feels that winters are becoming increasingly cold. There is cold intolerance over the past 3 years. Her appetite has reduced. She feels constipated. Her periods have been usually heavy for past 9 months. Her hemoglobin level was low, so she started taking iron supplement on advice of her general practitioner. She also has complaint of pain and numbness in lateral half of her hands, particularly when she rise up from her desk, placing them on table for support. So this is a typical symptoms of the carpal tunnel syndrome. She has a menstrual abnormality, constipation, she has fatigue, she has lethargy, she has depressed mood, as well as she is not feeling well, and she has menorrhagia. So the examination, lady with cold, rough and coarse skin. She has a slightly hoarse and croaky voice. Now the hoarse voice is always points a finger to the hypothyroidism. If you have seen a case of gross myxedema, gross hypothyroidism, and if you have listened to the voice, you will never forget it. A mild diffuse goiter was noted. Pulse was 56 beats per minute, so there was a bradycardia. BP was 150 by 95. There was a mild hypertension. There was no history of hypertension in the past. Non-pitting edema feet, non-pitting pedal edema. In other conditions like cardiac failure, like water hypertension, like in hypoproteinemia, there is always a pitting edema. If you put a thumb on the shin of tibia of patient, then there will be a pitting. But in this in the case of the hypothyroidism, this will be a non-pitting edema. Hypostasia over the lateral three fingers of both hands and delayed relaxation of the ankle jerks. This is a very important clinical examination. If you are when you are suspecting hypothyroidism, if you take the DTR, the deep tendon reflex, the relaxation will be slower. It will come gradually back. This patient was investigated. HB was 11.5, MCV was 104, so mean corpuscle volume was high, showing a megaloblastic picture, maybe a B12 deficiency, maybe some other disease. CPK was a bit high, serum cholesterol was 230, it was on higher side, ALT was 55, and the diagnostic was TSH, more than 100 nanogram per liter. So the TSH level, whenever it's more than 10, it stamps that the patient is having hypothyroidism. We will see the diagnostic criteria later on. The patient's ECG is showing severe bradycardia. You can see here the STT changes, the T wave depression, U wave is also seen. So evidently this patient is can be suspected having a cardiac problem. The chest X-ray was showing the cardiomegaly because of the pericardial effusion. So someone may suspect this patient as a cardiac disease and some tuberculous effusion of the pericardium. So what is the diagnosis? The most common endocrine disease is hypothyroidism. So in this case, all these cardiac problems, all this bradycardia, all these lab abnormalities is because of the hypothyroidism. So it is the most common endocrine disease. Yes, yet it is grossly underdiagnosed. Somehow the people are missing the diagnosis of the hypothyroidism. Female to male ratio is 8:1. The females are more. 90% patients have primary hypothyroidism. So we will mainly talk about the primary hypothyroidism because less than 10% have other causes. Menstrual irregularities, miscarriages, infertilities, growth retardation, weight pains, myalgias, arthralgias, anemia of unexplained cause, constipation, lethargy, cold intolerance, gain in weight, patient becoming obese, carpal tunnel syndrome, and the edema. These are the frequent complaints with which the patient can present to you. So whenever a patient comes to you with menstrual irregularities, miscarriages, infertility, growth retardation, weight pains, or history of carpal tunnel syndrome, think of the hypothyroidism first. How common is hypothyroidism? 5% of the general populations are subclinically hypothyroid. We will see later on what is subclinical hypothyroidism. 50% of all women more than 65 years of age are hypothyroid. So always suspect hypothyroidism when you come across an old lady. More than 65 years old patient, more than 50% will be hypothyroid. Detecting subclinical hypothyroidism in pregnancy is highly essential. So order TSH and FT4 routinely in all pregnant patients because the euthyroid status is very important for the brain development of the child, intelligence development of the child. Therefore, the pregnant patient has to remain euthyroid during the whole pregnancy period. All persons aged above 60 years order TSH. So lady mainly more than 65, all patients more than 60, pregnant lady, you should get the TSH level. Who has hypothyroidism? Hypothyroidism is common in people of every age. It can happen at every age, even at in the infants, in the children, in the young patients, and it's more common in old patients. It is more frequent in elderly, most common in females, as we have seen in the previous slide. The ratio from female to male is 8 as to 1. 1 in every 10 people have a thyroid disorders, and 1 in every 5,000 infant has a hypothyroid disorder. So hypothyroidism, you can divide into two parts. The iodine deficiency is the most common cause of the hypothyroidism worldwide. We all know that some endemic areas have iodine deficiency, and these patients can develop the hypothyroidism. In iodine sufficient areas, now the government of India, they run the campaign of iodized salt. This and it's going on since last almost a decade. Therefore, the iodine deficiency in India is now less seen, and so we are iodine sufficient. Still, we are getting so much cases of the hypothyroidism. Now, these are the autoimmune Hashimoto's thyroiditis. Hashimoto's thyroiditis, autoimmune destruction of the thyroid gland, which causes the hypothyroidism. So hypothyroidism we can divide into two parts, with goiter and without goiter. With goiter, iodine deficiency goiter, drug-induced goiter, the drugs and some due to some goitrogens, it can happen. If we see the causes of the hypothyroidism, the autoimmune hypothyroidism like Hashimoto's thyroiditis or atrophic thyroiditis are the most common. The iatrogenic like radioiodine treatment, if the patient has gone under a radioiodine treatment for the hypothyroidism, or a thyroidectomy for the hyperthyroidism or some tumor in the thyroid, or external irradiation of the neck, some radiotherapy is given for head and neck cancers, this all patients can land up into hypothyroidism. Drugs like iodine excess, this is called iodine constipation. Now there are two phenomena, John-Basedow phenomena and other phenomena. If you give iodine to this patient, the patient can land up into hypothyroidism. This is called iodine constipation. So excess of iodine can cause hypothyroidism. Lithium, antithyroid drugs, suppose a patient is diagnosed or misdiagnosed as hypothyroidism and the patient is taking carbimazole or methimazole, the thyroid function is not monitored and patient can land up after 6 months or year into a severe hypothyroidism. Iodine deficiency can also cause hypothyroidism. We all know how the T3 and T4 is made inside the thyroid. It is the monoiodotyrosine and triiodotyrosine and tetraiodotyrosine. So there has to be iodine's presence to make the thyroid hormones inside the thyroid gland. So whenever the iodine is not sufficient, it can cause the hypothyroidism. Infiltrative disorders of the thyroid like amyloidosis, sarcoidosis, hemochromatosis and scleroderma can also cause hypothyroidism. So types of hypothyroidism, clinically we divide into the primary, secondary and tertiary. Out of this we will only discuss about the primary where the problem is in the thyroid gland. Secondary hypothyroidism is because of the problem at the pituitary level, and tertiary hypothyroidism, the problem is at the hypothalamic level. Now we all know how the thyroid gland is controlled. There is a hypothalamus which is releasing the thyrotropin releasing hormone, which stimulates the pituitary to secrete the TSH, which stimulates the thyroid gland to secrete the T3 and T4. And this T3 and T4 has a negative feedback mechanism to the pituitary that reduces the secretion of the TSH. So whenever the T3 and T4 are low, the pituitary produces more TSH and therefore the TSH is high in case of the hypothyroidism. So in primary, the cause is in the thyroid. In secondary, the cause is in the pituitary, and in the tertiary, the cause is in the hypothalamus. Other causes are postpartum and drugs. We will touch it later on. So what are the symptoms of the hypothyroidism? The most common symptoms is fatigue. The thyroid gland is main gland which regulates the metabolism of the body. So whenever the thyroid hormone is not produced in enough amount, it will cause fatigue. The patient will gain weight. There will be a depression. There will be dry skin. Patient will have bradycardia, constipation, and intolerance to the cold. These are the main features the patient will have, and of course the edema. So, what are the signs? The dry skin, the cold extremities, puffy face, hands and feet, delayed relaxation of the tendon reflex, the carpal tunnel syndrome, the bradycardia, diffuse alopecia, and serous cavity effusions. There can be pleural effusion, pericardial effusion, and if the patient is severely hypothyroid, the patient can have ascites also. So dry skin is mostly seen in around 75% of the patient, cold intolerance in around 65, puffy face 60%, sweating in 54, weight gain in 55%, paresthesia is around 50%, constipation in 50%. So all these symptoms are around 50 to 60%, but dry and cold skin is in more than 75% of the patients. Look at this, the delayed relaxation of the ankle is seen in more than 77% of the patients. So if you examine very closely and do the DTR, and if you find the delayed relaxation of the ankle, then this has a very high sensitivity. Bradycardia is seen in around 55, somnolence, diastolic hypertension, depression, anemia, menorrhagia, and infertility. So many cases now presenting to the gynecs with the infertility. The cause is hypothyroidism. Uncommon presentation, hoarseness of voice. I will not call it uncommon, but I will call it late. Whenever a patient is not diagnosed having hypothyroidism, landing up into mixed edema, comes to the clinician after 5 or 6 years, this patient will have typical hoarseness of voice. Deafness, ascites, pericardial and pleural effusion, carpal tunnel syndrome, impotency, galactorrhea, amenorrhea. Galactorrhea is because whenever the TSH is overproduced, there is associated overproduction of the prolactin. This prolactin is not that high level like we see in the prolactin producing tumor or prolactin producing adenoma, but it's a little bit higher. That will cause the galactorrhea as well as the amenorrhea. Cardiac failure and psychosis. This is uncommon presentation. So, a depression will have feeling of guilt, loss of interest, thoughts of suicide, sleep disturbances. This can also happen in hyperthyroidism, but the hyper will have irritability, heat intolerance, palpitation, more sweating, muscle weakness, and tremors, or mainly the proximal muscle weakness. And this all can confuse, but we will remember that this hypothyroid can cause the depression and other symptoms. When they are co-associated, we can suspect the hypothyroidism. Differential diagnosis, other causes of the depression, dementia, Parkinsonism, and proximal myopathies. A patient of hypothyroidism will mainly have a proximal muscle weakness. So sometimes we can miss the diagnosis of proximal myopathies when the same presentation is there. Comorbidity, hypercholesteremia, infertility, menstrual irregularities, and diabetes mellitus. Mainly type 1 diabetes mellitus always screen for hypothyroidism, because so many times the antibodies which are found in the type 1 diabetes, these patients also have anti-TPO and anti-microsomal antibodies which can produce the hypothyroidism. So which initial test will stem the diagnosis? The TSH. TSH is the main test. And if you are asked in MCQ exam that which is third diagnostic test to do in a case of hypothyroidism, it will be TSH. If you still want an additional test to add, do the free T4. There is no role of total T3, total T4 TSH, or free T3, free T4 TSH. Only test has to be done one TSH, two tests, then TSH and free T4. So initial diagnosis is TSH is raised more than 3.5 to 5.5 according to the lab. Free T4 is decreased, total T4 is also decreased, but we will do only these two tests, free T4 and the TSH. So lab investigation will show TSH is high, free T4 has decreased, free T3 was decreased. If you do the ultrasound, that will be of little value. There is no role of ultrasound in hypothyroidism unless and until you see some enlargement of the globe, you are suspecting some tumor. Thyroid scintigraphy has little value. Anti-TPO antibody has some got value. We will see it later on, because this is an important test when we are dealing with a case of subclinical hypothyroidism. Other investigations, the CPK will be elevated little bit, nor not in the range of polymyositis. The ASC, LDH, cholesterol, triglyceride, all will be associated. A young female or an old patient presenting to you with hyperlipidemia, elevated triglyceride, always rule out the hypothyroidism first before starting the treatment of the hyperlipidemia. Anemia, it will be a normochromic, normocytic, like anemia of chronic illness. It can be a macrocytic anemia because of the problem with the B12 absorption in the intestine, or it can be a microcytic anemia because of the menorrhagia in ladies or iron absorption problems in the intestine. Increased serum prolactin, as I told you, this will not be in the range of sky high range of prolactinoma, but it will be little bit raised. That this can cause galacturia, particularly when these patients are given domperidone or perinom like metoclopramide like drugs. They can also increase the prolactin beat, and this combination of two, the patient can land up into galacturia. Patient can have a hyponatremia. When you do the ECG in this patient, we already saw in the second slide, sinus bradycardia, low voltage, prolonged PR interval, Brundle branch blocks, flattening or inversion of the T wave. That slide showed the inversion of the T wave. Ventricular premature contractions can be there. Sustained or non-sustained VT, which is very rare. This is not seen commonly, and prolongation of the QT. So it's very important whenever you are coming across a hypothyroid patient, measure the QT interval, and we have to be cautious in giving some drugs like hydroxychloroquine or azithromycin and other drugs which causes the problem of arrhythmia with prolonged QT syndrome or the prolonged QT because of the hypothyroidism. The differential diagnosis of the elevated TSH is, first diagnosis is primary hypothyroidism, second is transient elevation of the TSH. Suppose this patient has a thyroiditis, there is transient loss of the function of the thyroid gland, so TSH will rise, and even if you don't treat, the TSH become normal after some time. Pituitary adenoma, if it is a TSH secreting pituitary adenoma, then the TSH will be high, and this patient will have what we call the secondary hyperthyroidism. The cause is in the pituitary, the TSH is high, but the free T4 also will be high. So TSH high, free T4 low is hypothyroidism. TSH high, FT4 is also high, is secondary hyperthyroidism. Primary adrenal insufficiency, T4 resistance syndrome, the T3 and T4 are produced in enough amount, but there is some resistance at the tissue level, just like a type 2 diabetes. The T4 is not working properly, and TSH resisting at receptor level. The TSH is produced from the pituitary, but the thyroid is not responding to the TSH produced from the pituitary. So this all can cause rise in the TSH, but this is not a hypothyroidism. So free T4 is low and TSH is low. This is a condition where we call the secondary or tertiary hypothyroidism or a central hypothyroidism. The problem is at the pituitary level, like Sheehan syndrome. Now pituitary is one of the most vascular structure of the body. It is getting the largest amount of the blood supply. So whenever a patient has a postpartum hemorrhage, the first organ to be deprived of its blood requirement is pituitary, and it is called pituitary apoplexy. The pituitary is deprived of its blood supply, and if it's not given to it in a fixed time, the pituitary will die, it will lose its function, what we call the Sheehan syndrome. So in Sheehan syndrome, there will be no TSH, there will be no growth hormone, there will be no FSHLH, and there will be no ACTH. So this all will lead to so many endocrine problems at the same time. It's a big subject, we don't touch to it, but remember that whenever the free T4 is low, the TSH is low, we are dealing with a central hypothyroidism. The problem is at the pituitary, or there is a tertiary problem at the hypothalamus level. The treatment goal is the improvement of the symptoms. The patient should have a normal life. Remember, these hypothyroid patients have a very low quality of life. So a good quality of life, normalization of the TSH gradually, don't go too fast, reduction of the goiter size, and please avoid the over supplementation. So many gyms in the metro cities and big cities, they are using this thyroid supplement to induce the weight loss in the people coming to the gyms. This is a very hazardous because it can cause atrial fibrillation, this can cause embolization, this can cause stroke, embolic stroke, and there is always a risk of bone loss. Whenever you are supplementing the thyroid hormone, there is a problem of osteoporosis. fast or a speedy osteoporosis. Therefore, people give calcium supplementation whenever they are giving the thyroid supplementation. So we just avoid the over supplementation in this patient. So the diagnostic graph of hypothyroidism, whenever you are suspecting a hypothyroidism, you measure the TSH. If it is elevated, you measure the free T4. Now, if the elevation of the TSH is more than 10, then you can straight away stamp this patient as hypothyroidism. There is no need to measure the FT4. As per the Indian Thyroid Society guideline, if the TSH is more than 10, you straight away start the treatment. If TSH is between 4 to 10, you can do two things. What we call, this is something called subclinical hypothyroidism. This patient is not grossly hypothyroid. There are all the chances that this patient might not have all the clinical signs and symptoms of the hypothyroidism, but the patient's TSH is found elevated during routine screening of infertility or other cause. Now, whenever this TSH is between 4.5 to 10, you measure the FT4. If the FT4 is low, this is primary hypothyroidism. But if you still want to confirm, do the anti-TPO antibody. If it is positive, it is Hashimoto's thyroiditis causing the primary hypothyroidism, and you have to treat this patient. If you measure the FT4, it is normal. If the TPO is positive, this is a subclinical hypothyroidism, you treat this patient. If the patient's FT4 is normal, TPO is negative, then this patient is not having subclinical hypothyroidism. You do the annual follow-up with this patient, closely monitor. This patient can land up into a gross hypothyroidism in a near future. I am not touching this part of CQ thyroid, but just remember normal TSH, but you still are feeling that this patient is having features of hypothyroidism. You measure the FT4, it is normal, just leave the patient. If the FT4 is low, consider this patient might be having a sick euthyroid syndrome. We will touch it later on. So in short, if TSH is more than 10, patient is grossly hypothyroid, you start the treatment. If TSH is between 4.5 to 10, it is a subclinical hypothyroid. You measure either FT4 or you measure the anti-TPO. According to the Indian Thyroid Society, there is no need of FT4. You directly go for anti-TPO. So TSH 4.5 to 10, do the anti-TPO. If it is positive, you start the treatment considering this patient as a subclinical hypothyroid. If the anti-TPO is negative, there is no need to give thyroid supplement to this patient, and you monitor the TSH annually. If the TSH is less than 4.5, then patient is normal and you don't need any treatment for this patient. So this is a graph which this is a table which explain how you can approach to the patient who is having a high TSH level. So how to treat? The adverse effect is angina patients having occult IHD and osteopenia. Suppose a patient is having hypothyroidism and you start the treatment with the thyroid supplementation. There are all the chances that the stable angina patient or stable IHD patients, stable CAD patient can become unstable with the thyroid supplementation, because suddenly the heart rate rises, the cardiac contraction becomes forceful, the force of the contraction increases, and second problem is osteopenia. So whenever you are having a patient who is having acute MI, there are all the chances of arrhythmias, and this cannot be used as a treatment of obesity and uncontrolled hypertension. You go slow in these patients. Goal is to normalize the TSH level and to give the good quality of the life. Always use the once daily dose, and remember 80 microgram per 50 kg. It is around 1.5 to 1.6 microgram per kilogram per day to around 2 microgram per kilogram per day. So 80 to 100 microgram per day before breakfast, empty stomach, takes any food after 30 to 40 minutes after taking this tablet. So we start with this in most of the patients. Monitor TSH level at 6 to 8 weeks. If it is not achieved below 4.5, you increase the dose according to your practical experience. And once the patient is stable, you repeat the TSH every 3 to 6 months. So you start with 1.6 to 2 microgram per kilogram per day, empty stomach before the breakfast once a day. First monitoring is to be done at 2 months, and subsequent monitoring is to be done at every 6 months. Dose of levothyroxine depends on the degree of hypothyroidism. Suppose patient is having TSH of 40, one patient is having TSH of 100, and one is having TSH of more than 150. Then we have to give the dosage accordingly, according to the age of the patient. If the patient is young, you can start the treatment with 100 microgram of the tablet. But if the patient is old, if the patient is having some cardiac problem, don't start with 100 microgram, go slow, start with 50 or 25, and gradually you increase the dose. Look at the general health of the patient. Usually daily replacement, as I told you, is around 1.5 to 2 microgram per kilogram per day. Start with the low dose, particularly in cardiac patients and in elderly. Levothyroxine, if no residual thyroid function, then you give 1.5 microgram per kilogram per day. Suppose the patient has thyroidectomy, radioiodine, you start with this. Patient under the age of 60, as I told you, if the patient is old, you start with 25 or 50 microgram per day and gradually increase the tablet strength according to your TSH level. In elderly, especially those with CAD, start with 12.5 to 25 microgram per day and gradually increase the dose. Now, dosage adjustment in elderly, start with the half dose. Severity and duration of the hypothyroidism, you will need more dose. If the TSH is high, if the patient is having total thyroidectomy, total irradiation of the thyroid gland because of some radiotherapy or radioiodine therapy was received, there is no thyroid tissue, then you will need a high dose. You can go up to 3 microgram per kilogram per day. Suppose a patient is weighing around 50 or 70 kg, you can go up to 150 to 200 microgram per day. But if still you are not getting the normal TSH level, think of the other causes. We will see mainly the malabsorption. Suppose the absorption of that tablet is not proper. Suppose the patient is taking calcium, iron supplement, sucral fat, then the tablet will not be absorbed properly. Suppose the patient is not following the instruction of taking on the empty stomach, taking it with food, then the tablet will viability of the tablet will be less. Suppose the patient is not closing the cap of that bottle of the thyroid tablets properly, then the moisture will enter inside the bottle and the tablets will not work properly. Empty stomach is most important. Pregnancy, whenever the patient is pregnant, there is 25 to 50% increase in the dose. So, and it's very important. We will touch the topic pregnancy and hypothyroid in subsequent slides. And presence of the cardiac disease. Always start with alternate day therapy in these patients, and gradually you increase the dose and you can maintain then daily therapy. Now, how the patient improves? It is not that you give the tablet and the patient feels better in few hours or few days. It will take 2 to 3 weeks, 15 to 20 days. Reduction in weight is the first improvement. Facial puffiness then starts coming down. First, the patient will lose the weight, then the puffiness will disappear. The skin changes, hair changes take long time to regress, mostly 6 to 8 months. So, a brittle skin, a papery skin, dry skin will take 6 to 8 months to become normal. TSH starts showing decrement from the high values. TSH returns to normal eventually, and there will be decrease in the cholesterol level. So you see, first the patient will feel better, then the weight will reduce, then the edema will go, skin changes will gradually become normal, and then the TSH will become normal. So don't monitor TSH too frequently. Don't go for weekly, twice weekly, monthly TSH. Wait for at least 6 to 8 weeks on the first or second visit, and then when the patient is stabilized, do the TSH level every 6 months. As I told you, serums, TSH level after the first consultation, repeat on the 6 to 8 weeks. And once it is achieved normal, you achieve the normal level of the TSH, do TSH at every 3rd or 6th month. Target TSH is between 1 to 2 microunit per liter. Once a stable TSH is achieved, it should be estimated every year or half yearly, 6 monthly. Now, better to do only TSH when you are monitoring, but still you can go for FT4 and TSH both. LFT not much necessary, and CBC not much necessary in hypothyroid. In hypothyroid, we have to monitor the CBC. And once euthyroid stage is obtained, you do the TSH every 3rd or 6th month. Now, hypothyroid and pregnancy. During pregnancy, requirement of thyroxine will rise. As we saw, there will be 25 to 50% increase in the dosage. Even on mild thyroxine hormone deficiency, there are chances of low IQ and developmental delay of the child. So the rule is during the first trimester, you keep the TSH below 1.5, 1.5, not 4.5. During second and third trimester, you keep the TSH below 2.5. So 1.5 below 1.5 in first trimester and below 2.5 in second and third trimester is the rule in the pregnancy. So diagnostic criteria of hypothyroidism in pregnancy is different. Anything more than 1.5 TSH in the first trimester, you have to start treatment. Anything more than 2.5 in second and third trimester, you have to start the treatment. If you don't start, the child will have a low IQ, developmental delay. So it's better to start the treatment. Now, thyroid hormone exists in two forms, the free, active, or bound with the protein. In pregnancy, increase in the estrogen increases the thyroid binding globulin, which will in turn increases the total T3 and T4. Therefore, in pregnancy, always measure the free T4 and not the total T4. In other case, also we are measuring the free T4, but this is just an MCQ question that why we are not measuring the total and T3 and T4 in pregnancy because of the highs in the TBG. So free T4 should be measured in pregnancy. Levothyroxine in pregnancy, same treatment like a non-pregnant, but the goal is normalize the TSH, and TSH level is different as I told you. First trimester less than 1.5 and second and third trimester less than 2.5. As adjust dose at every 4 weeks. In pregnancy, you have to do the TSH level monthly. We cannot leave the patient for 2 or 3 months. You have to monitor on the first visit 15 days, that is 2 weeks. And if you achieve the normal TSH, then you do the TSH every 4 week interval. And that is if the patient is no euthyroid, then you check the TSH at every end of the trimester. Suppose the patient is normal, TSH is 1 or 0.8 on the first visit, you do the another TSH level at the end of the first trimester. If it is normal, then you do at the end of the second trimester. This is the typical appearance, what we call the myxedema phase. You can see the puffiness, the loss of the eyelid, what few people call the Mona Lisa face also, loss of the expression. This will be a fixed face like a Parkinsonism, and all this puffiness around the eyes and the round face. Same way here, you can see the loss of the eyelids, sorry, the eyelashes. You can see this puffy face, the edema around the eyes and the round face. Mixed edema coma is a medical emergency. It occurs in previously undiagnosed hypothyroidism patient, or suppose the patient has stopped the treatment and comes to you after 1 month, 2 months in a comatose patient. The elderly patients are more susceptible and it is a medical emergency. Precipitating factors, the patient of hypothyroidism going into mixed edema are infections, sepsis, drugs like sedatives, antidepressants, anesthetic agents, cardiac failure, respiratory failure, cerebrovascular accident, GI bleed, hypoglycemia, hyponatremia, hypercapnia or hypoxia. This all can lead. So all the organs, heart, liver, kidneys, electrolytes, all can cause the mixed edema coma. The signs and symptoms will be hypothermia. The patient will be very cold, coma, seizures, other features of the hypothyroidism. Whenever you look at the patient and you feel that this patient is grossly myxedematous, and the patient in coma, the first diagnosis is myxedema coma. Bradycardia, hyponatremia, hypoglycemia, the more CO2, less WBC count, hematocrit is less, and rise in the CPK and EKG voltage. If you look at the ECG, it will be a very low voltage with typical bradycardia, inverted T and U waves. Treatment is shift to the ICU, and if possible, if available, give IV levothyroxine. It's not available in India. So 500 microgram bolus followed by 50 to 100 microgram per day. Same like what we were giving orally. But we have to give 5 times of the normal dose, that is 500 microgram IV bolus, and then we continue 50 to 100 through nasogastric tube. If the levothyroxine IV is not available, what we do is we give 5 tablets of 100 microgram through nasogastric tube, and most of the time this will serve the purpose. Antibiotics, ventilatory support, hydrocortisone IV, steroid is always should be given whenever the patient is in myxedema coma. Passive warming, careful volume management. Don't keep this patient in air condition. He is already hypothermic. Correction of hypoglycemia and hyponatremia. Myxedema madness. Whenever the patient is crazy, when being crazy is not in your head, but it is in thyroid. Sometimes The hypothyroidism can also cause the madness. Delirium with auditory hallucinations, paranoid delusions, takes the form of psychotic depression or pure psychosis and no cognitive impairment. Treatment is thyroxine. So whenever you come across a case of severe psychosis, delusions, in mainly in old age patient, think of the thyroid first and psychiatric problems second. Sick thyroid, as I mentioned in previous slides, the total T3 is reduced, FT3 is reduced, FT4 is normal, TSH is normal, clinically patient is euthyroid. We call this patient as sick euthyroid syndrome. So when to screen for a patient with hypothyroidism? Whenever any lady of more than 60, any male of more than 65, woman with a family history of thyroid disease, prior thyroid dysfunction like history of Graves' disease, thyrotoxicosis, received radioiodine, symptoms suggestive of hypothyroidism, weight gain, edema, patient is not tolerating the cold, abnormal thyroid gland on examination. If you are seeing the goiter is there, case of type 1 diabetes, personal history of autoimmune disease, always screen for a hypothyroidism. That ends my today's talk on hypothyroidism. Thank you. If there are any questions,